Hello, I hope you guys are doing well today. Today we are going to talk about range of motion. So, overview of the lecture, we are going to talk about the nature of the range of motion, types of range of motion, effects of range of motion, indications, contraindications, and precautions, procedures, observations, findings, and progression. Just a reminder of your osteokinematics and your arthrokinematics. Remember, osteokinematics are the long bone movements. So if I'm flexing my shoulder, the long bone movement, I'm talking about the humerus is going superiorly as I flex up. That's an osteokinematic. In the picture, if you are sitting and doing knee flexion and extension, then the femur is fixed while the end, the tibia and fibula are moving on the femur versus, so that's the open pack position, versus if you're in the closed pack position, you're standing doing squats, the bottom portion of the leg is fixed and the femur is moving around that portion. Those are all osteokinematic movements. Versus arthrokinematics are the movements of the joints, and we're typically talking about roll and glide. There is some spin as part of the accessory movements, but roll and glide are really what we're concerned with, and we use glide to determine what type of joint mobilizations to use. Our cardinal planes of motion, the sagittal plane is if you cut your body in half that way, so flexion and extension. So how I remember that, if I had something here, and I was able to move along that. So like if I could put my arm on it and move up and down, if it was laying still and I'm just only going up and down in that plane, that's how I remember which plane of movement things occur in. So if it's sagittal, then it would be up and down like that. If it's frontal, it's more of those side to side movements that would, be connected to that paper if I was going up and down. And then if it's transverse, it's more of the rotational movements. So if I had a pen in my hand, I would be able to draw on the paper if I was rotating. Here, I would be able to draw on the paper if I was doing flexion and extension. And on the side, I would be able to draw on the paper if it was way out here, if I was doing abduction and adduction. So that's how you determine what plane of motion each of your movements go in. And if it's triplanar, of course, it's various planes. It's two or more planes are being used at the same time. So more of your diagonal patterns, inversion, eversion movements like that. Supination, pronation, combined movements. Joint range of motion, we use this to assess the amount of movement that is available between two bones. We also use it for treatment, so moving a joint through its available range and in hopes of gaining more available range. And just to kind of a caveat, range of motion is not stretching. It's different. Typically, range of motion is done slowly, and you may hold for a few seconds, 3 to 5 maybe at the end range, whereas stretching you really should hold for at least 30 seconds. So the goals are different from range of motion and stretching, and the method is different, and the amount of hold time is different for each. You can incorporate some stretching with range of motion. Once you're at the end range, hold it longer, but they're not the same thing. Also, at the bottom of this slide, if you look at your PowerPoint, there's a little message about, unless I put it on the next slide, no I didn't, about your capacity of mobility. So in order to have the capacity to move, we're not just looking at one thing, we're looking at all the structures involved, bones, ligaments, tendons, soft tissue, and how it moves, even skin. If you have a significant burn and a large scar that's immobile, then that can limit your range of motion as well. So your ability to move through your range of motion depends on a wide variety of things, all the structures involved, and not just one thing. Here are just a list of the joints throughout your extremity, and then the axial joints that's connected to the spine itself. You can read through that list. I'm not going to read it to you. Diagonal range of motion. So PNF patterns, that's proprioceptive neuromuscular facilitation. Those are patterns that are used, they're diagonal patterns that are used to mimic our functional movement, and they combine several planes of movement, and typically they'll go across the body and combine flexion and extension type of movements. In order to be a true diagonal pattern, it needs to have all three components. So whether it's flexion or extension, abduction or adduction, and internal or external rotation. So like with the diagonal patterns, you internally rotate, extend the shoulder, and abduct. You go from that position to external rotation, flexing of the shoulder, and abduction. And so all those components of movement are combined for those diagonal patterns. We name it by the ending position. So if we were doing arm movements and we ended with the shoulder flexed, then it would be called a flexion pattern. If we ended with the shoulder more towards extension, it would be called an extension pattern. We'll cover that some in your Rehab and Kines 2 classes, but definitely in your Rehab 2, the second Rehab class. And the diagonal patterns are typically more functional. Muscle excursion or muscle length. So when you have a muscle that crosses two joints, for example, the quadriceps, it crosses the knee and the hip joints. If you are trying to assess the length of the muscle, then lengthen it over both joints at the same time. So for the quadriceps, you would have the hip straight and the knee bent, and now you're pulling kind of both ends of that muscle to determine if it's tight. If you're just trying to assess joint movement, joint range of motion, then you need to put that muscle on slack. So if, for example, you're trying to see how far the hip can extend, then straighten the knee, so that if the knee is bent, you're pulling on both sides of the quad, but if your knee is straight, you're able to assess how far the hip can extend. So in the same way, the example here is in the first picture, she's testing how far the hamstrings can extend. She's keeping the knee straight, and she's just going as far up as the patient's body will let her. And then to assess hip range of motion, she's bending the knee so that the hamstring tightness doesn't stop her. Different types of range of motion. We have passive range of motion where an external force is moving the joint. Typically with PT, it's the therapist that's moving the joint. With active range of motion, the patient's muscles themselves are moving. So you're actively moving your own body part. And with active assistive, it's a combination. Typically, we have them go through in range, and then we push them the last few degrees of their available range. So it's a combination of active and passive range of motion. Benefits of passive range of motion. It stimulates tissue healing. It prevents adhesions like scar tissue developing and prevents joint stiffness. Benefits of active range of motion can include the benefits of passive, but also it helps maintain health, integrity, and elasticity of the tissues, straightening and moving the area to maintain that good muscle elasticity. It increases sensory input, promotes tissue alignment. So after an injury, as scar tissue lays down, it's kind of laying down like leaves in a pile. It's just a big bundle of mess. But as you move it and the tissue around pulls it, it elongates it and allows it to realign in a more similar pattern to its original alignment, to the muscle surrounding it. So it becomes more usable, more functional, and less rigid in the area. So it's really important to move an area as it's healing so that the scar tissue realigns. If you don't move it while it's healing, the scar tissue will just stay in that bundle and it will restrict movement once you start to move it. And then the skeletal muscle pump, remember the gastroc, for example, in your legs. As you do ankle pumps, the muscle pump pushes on the veins in your legs to push the blood back to the heart, so it increases your circulation. Okay, why would we do passive range of motion? Some of the times that we would do it is if a patient is not able to do active range of motion. Maybe they don't have enough strength or it's too painful, then you can do passive. If it's contraindicated, maybe they had a shoulder surgery and active movement would pull on the muscles that were just now sewn together and pull apart the surgical site, then we would do passive range of motion. If we are trying to assess and see, the patient's only getting to here, and we want to know, is it because they're too weak to go any higher, or is it because their shoulder is really swollen and they can't go higher? And so we passively move them and see how much range really is available. And as an intervention, we go through the range of motion to help, the circulation and tissue healing and all those benefits for the patient. Pendulum exercise. So this is typically one of the first exercises given after a shoulder surgery. The patient either lays in prone or stands. I always show it in standing. And they actually move their hips and the arm just hangs. So you're trying to relax the muscles so much that the movement of the hip causes the arm to swing back and forth like a pendulum. So your arm is not actively swinging itself, it's just hanging limp. And the body movements cause the arm to swing in different directions. So gravity is actually causing it to move. It's really hard to teach patients that. They want to stand there and just twirl their arm around, which is active movement. It's not what we're going for. This should be more of a passive exercise. And the reason we do it is it helps loosen the area and promote blood flow, promote circulation. And also it helps with pain gating. Pain gating is when you have one signal, pain, rushing to your brain. If you give another signal like light touch or movement, that signal also goes to your brain, and it can kind of beat the, if they're in a race, the pain signal and the light touch signal are in a race to your brain, then it can kind of beat out the pain signal so that your brain forgets about the pain as much. So typically it doesn't take you from a 10 to a 0, but you might go from a 10 to an 8 or something like that to help your body pay less attention, your brain pay less attention to the pain. That's pain gating. And whenever we bump our elbow and we grab it and we start shaking it, that's exactly what we're doing. And when mommies kiss boo-boos and make it feel better, that would be pain gating. All right, so our passive range of motion, contraindications, reasons we would not do passive range of motion. If the motion is going to interfere with your tissue healing, let's say they did a surgery and they saw that the muscle was really fragile, and then they may say no passive range of motion for a certain amount of time until it heals so that you don't tear the muscle apart. If the patient has extreme muscle guarding, like they're stuck in one position, then if they're not able to relax to allow you to move it, they're actually going to be actively fighting against you, and it's actually going to cause more stiffness, more muscle tightness, and more pain. So if you cannot get the patient to relax because they're so in so much pain that they're all guarded, then passive range of motion is not going to provide any benefits. You'll have to get them to relax some before you're able to do it. And same with if the muscle guarding is associated with pain, which is pretty much why they are muscle guarding in the first place. Now, precautions. Remember, these are not necessarily indications that say you absolutely can't do it, but you just start to hesitate and say, what's going to be better? Do I benefit more, or is there more of a risk if I'm doing passive range of motion? So if it's going to temporarily increase the patient's pain, most of the time, everything we do in PT is going to cause a temporary increase in pain. Some of it will help decrease the pain as well. So you just have to see how much pain the patient's in to determine what's best for them. And if it elicits an undesired muscle tone, like for example, they start to tighten up every time you start to move it, have some type of reflexive action when their limb is moved, then you would not do passive range of motion. And in situations like this, you could possibly try passive range of motion, just do really small movements, really slow, get them used to it and see how their body reacts. And if immediately they start to tighten up or say they're in more pain, then you can stop and try a different treatment technique. All right, these are characteristics of a patient's condition to inform clinical judgment. And so basically, these are things that you look at to determine is passive range of motion a good idea or not. So you can remember by SINS, SINSS, severity of the condition, irritability, how easy it is to irritate that or aggravate that muscle. Nature of the condition, did they have a recent surgery or recent fall? Stage, like stage of healing. Are they 3 days out of a surgery or has it been like this for 6 months? And stability of the patient's condition. So all of that you take into consideration to determine if it's safe to do passive range of motion. And most of the times passive range of motion is indicated. You just may have to do it gently or slowly, but be careful with those who are in extreme pain or extreme fragile conditions. Dosage. This is kind of what we typically use for passive range of motion. Now the little squiggle is around around 5 to 12 reps, typically between 5 and 10 seconds per cycle. So you go up slowly and hold it for a few seconds and down slowly and hold it for a few seconds, 5 to 12 times. And typically we're going to want range of motion, passive range of motion be done 3 to 5 times a week. Now for somebody who's in a very, like let's say maybe a coma or something where they're not moving at all unless you're moving them, then ideally at least once a day for somebody like that. So with neurological conditions and with extreme cases, the dosage would change for those patients. With many of the neurological conditions, you have to take into account that any type of quick movement is going to cause them to have spasticity. That's kind of a quick muscle tightness against that movement. And so really slow movements and holding for a little bit longer time to decrease the amount of stimulation and keep them from becoming spastic with the movement. Active range of motion, some of the contraindications would include all of those we discussed with passive range of motion, as well as pain throughout the motion or persisting after the activity. So if just them moving it on themselves puts them in a lot more pain, then next time to avoid the active range of motion. They're not quite ready yet. If they're developing more tone with active movement, if they're in cardiac distress, or have any other adverse response to exercise like inflammation, effusion is just inflammation within the joint, then they would not be a good candidate for active range of motion. Of course, if they've had a recent surgery, typically it will say in their chart if they're allowed to do active range of motion. I put this picture because most people after shoulder surgery will have a big bulky brace like this initially, and they will only be allowed to take that off for therapy. And the main things they can do in therapy at that point is just passive range of motion. They're not quite ready for active yet. And so really looking at the doctor's orders can help you determine that. The precautions with active range of motion are the same as passive, plus if it generates undesired movements, so that is like compensatory movement. So if you're saying bring your shoulder up and they're raising it up like that in order to raise it up, that's compensation. So now they're strengthening the wrong muscles and they're going to create more of a muscle imbalance. You don't want that. If the physiological demand increases the patient's risk. So I have this picture of a patient, with a nasal cannula with oxygen going in through the nose. If somebody already is at such a low level of oxygen that their body is already struggling to keep up, you don't want to add any active movement. It's like exercise or anything else. The more movement you do, the more oxygen demand on the body. And if they're already in overload, you don't want to push them any further because then it could actually deteriorate their condition. For the dosage for active range of motion, it's really determined by the patient. So you just watch for signs of fatigue. Some of the signs are like shaking or inability to go as far through the range of motion. They're starting to do less and less each time. Pain, changes in the quality and accuracy of the movement. If before they're able to come straight up and straight down, and now they're shaking on their way up, or they're kind of going into the side and pulling other muscles in, then that they've reached kind of their limit for that exercise. And changes in vitals. If their heart rate goes too high or respiratory rate too high or oxygen too low, anything like that, you would want to stop and let them rest and recover. Choosing a plane of motion. So that is determined by what's your objective. So for the straight plane of motion, this is more specific and thorough. So if I want to determine how much shoulder abduction does someone have, I use one plane of motion, I get a measurement, and I know based on my joint mechanics, arthrokinematics, and things, what types of things could limit that movement. So then I know what joint mobilizations to do, what stretches to do, all that by looking at that single plane of movement. It isolates the movement and it's appropriate for your exam. It's also appropriate for treatment. Most of our passive range of motion is in a straight plane of movement so that we can target one exact movement. Whereas diagonals combine two or more straight planes, and they are more functional. They're more like our normal functional movements, but they don't allow for that isolation. So if I'm wanting to really increase shoulder flexion, but I'm doing diagonal patterns, now I'm actually working on several planes and several movements, but I'm not really getting as much emphasis or practice on shoulder flexion as I would with a straight plane. But as the patient progresses and they're returning to their function, they're doing maybe resistance training or anything like that, you definitely want to add in diagonal movements because typically in our normal day, diagonals are what we do, more functional. Body mechanics. We want to get close to the patient. When possible, you kind of support with your arms, but move with your legs. You kind of squat or lunge and rock side to side as you're moving the patient rather than using all your arm strength to move their body part. You will wear out and it can be a lot on your arms. So you need to widen your base of support. You need to face in the correct direction so that as you move your body, you're going with the plane of motion. And if you're watching them do active range of motion, make sure that you're at a safe distance so that they can have full range without bumping into you. But that you can still have a good look at exactly what they're doing. Some of the procedures. So we stabilize the proximal joint. So for here, if they're doing elbow range of motion, the therapist is stabilizing just above the elbow, proximal to that joint, and mobilizing distal to the joint. So down at the wrist, or it could be even closer to the elbow. But the lumbrical grip is this grip she's using there, kind of like you would grip a water bottle. That's how we typically will grip the patient's arm, that lumbrical grip. And then CCDD is that control centrally and direct distally. That's why we stabilize proximally and move the distal portion because we're controlling the proximal portion and then getting our movement distally. AMAP, ANAP, that means as much as possible, as naturally as possible. So you want to get as much movement as you can, but want it to be done naturally. So you don't want to use compensation and odd patterns of movement because it's not going to be functional for the patient. And then a systemic approach, so kind of look at the patient's whole body, and you can sometimes, like let's say they have spasticity throughout their arm, you can kind of combine movements where you flex the elbow and then flex the shoulder and then straighten the shoulder and then straighten the elbow. So you're kind of combining movements to do several range of motion procedures at once. With passive range of motion, you want to go slowly and hold just briefly in range. At the end, you can also add just a little bit of overpressure to get those last few degrees of range of motion, and that can kind of help stretch the capsule and help stretch the muscles surrounding so that the patient can eventually progress and get more and more motion. With active, you just tell the patient what to do. You may even demonstrate, and then you watch and assess their quality of movement and their response to the activity. Kind of ask them, how is your pain now? Watch their face to see if it looks like they're in more pain, and watch out for compensatory movements. Make sure that they're not, if they're trying to go in and out, that they're not pulling their whole body to move in and out. Observations and findings. So these are the things we're assessing. I've talked about a lot of them already. Quantity of movement, how many can they do, how many reps. Quality, is it shaky, is it smooth, is it, are they pulling in other muscles, or are they able to single out the muscles that are supposed to do that movement. Patterns of movement, are they bringing in flexion, extension, or rotation with the movement, or are they able to isolate one movement? Endfeels, we'll talk about those in just a minute, but that is the feel that you get when you get to the end of the movement. So as you do more passive range of motion, you'll be able to assess and say, okay, now I'm at the end, it feels soft, or it feels hard, it feels firm, it feels springy, and those tell you what is blocking the movement. Is there two bones that are now at their very end range, and that's a hard infeel, is two bones hitting each other, or is there a muscle in my way? My biceps are just so bulging that it's in the way. That's a soft infeel because there's a soft cushion that's blocking that movement, and that can help tell you why their movement is limited. Pain, assess how much pain they're in before, during, and after. Look for muscle tone, spasms, or guarding, and then listen for the sound. Sometimes you'll hear a popping or a clicking noise. Maybe the patient will report that they feel a catching sensation. Pay attention and record all of that. These are the infills I was just talking about. As you put just a little overpressure at the very end of their movement, then you can determine what their infill is. So soft means that there's a muscle in the way stopping your movement. Firm is typically the capsule itself that surrounds the joint stopping the movement, and so the capsule is tight, and that's when joint mobilizations are indicated, when they have a tight capsule. Versus hard is when two bones are blocking the movement, like elbow extension, that it's just not going to go any further because the bones are at the very end of their limit. So if, let's say, you were moving the elbow and you expected there to be a hard infill, but in the middle range there was a firm infill where you felt like there was a kind of a sticky feeling and it just couldn't go any further, then you would know, okay, now the capsule in the elbow is tight. I need to stretch that in order to get to its normal infill so that I can increase the range of motion. So it means, something is going on, something is tight where it shouldn't be, and we need to work on that to get the normal range back. An empty infill basically means I didn't get to the end. Nothing stopped me, but the patient either pulled away or said stop or said that hurts too much. And so empty infill is basically related to pain. You could not get to the end of the range of motion, and that's always abnormal. I mean, pain should never be what stops us from getting full range. So that just tells you that you haven't reached in range yet, and for whatever reason, it's too painful to get there. Sometimes we will record that as movement is limited by pain, but you can also just put empty infill. Okay, so there are various patterns of movement. We'll talk more about this in Kines 2. You may be learning about it some in Kines 1 this semester. There's capsular patterns, and essentially what that means is in every joint with different movements, there's capsular patterns that say if the capsule is tight or if it's limiting the movement, then you would expect that this motion is the tightest, then this, and then this motion is the least limited. So it's a pattern of movements that say these movements are typically the most limited, these are the least limited, and that tells you that the capsule is what is limiting those movements. So if you notice while you're assessing somebody's hip range of motion that when these areas are really limited and these are not so limited, and it follows the joint capsular pattern, then you know the joint capsule in the hip is tight and you need to do some joint mobilizations to stretch it. Non-capsular patterns don't follow those patterns, and so then you say, okay, it's not a tight capsule, there's something else. It could be joint effusion, there's swelling in the joint. It could be a tight muscle or a contracture or anything like that that's limiting the joint, but you know it's not the capsule itself. So then joint mobilizations are not indicated. So this really determines how we treat the patient and what we focus on in order to gain the range of motion. And then just look at the coordination of movement and what all they bring into a movement. If they're moving an arm and they can't move it without also moving their trunk or moving their head or whatnot, paying attention to that to get ideas of kind of how you need to treat that patient as well. Self range of motion, so typically we call it active assistive range of motion. They can also do passive range of motion. So the patient uses one arm to mobilize the other or uses their arms to mobilize their legs. So they're doing basically a passive range of motion on themselves. You could also consider it active assistive range of motion because it's really hard when you're using one arm to lift the other not to also activate the arm you're using. So if somebody had active range of motion contraindicated, they weren't allowed to do it, I would not suggest this because it's really hard to relax while you're moving it. But they could use, they could use pulleys, they could use a cane or a wand. You've probably seen those in the clinic where they have wand exercises, and that's a self range of motion technique. Typically, we progress from passive range of motion to active assistive range of motion to active range of motion. So first, you're moving it for them, then they're moving it as far as they can and using passive to get those last few degrees, and then they're at a point where they have good range of motion and they're just moving their arm through the range or their leg. So it could be also their head, neck, trunk. It doesn't have to be just an extremity, but they're moving it through the available range in order to keep what range they have and possibly even get more range, but also as a way of strengthening so that they can reach their end range. All right, so the main things that we need to know from this lecture, we need to know why you use passive versus active range of motion, when they would be contraindicated, when you should not use it, how to use your clinical judgment in determining which is best for the patient. And remember, passive range of motion can be done in a straight plane, which is typically more used for assessment or for gaining range, or in diagonal planes, which is more used to get them back to their functional abilities. Pay attention to their form, especially with active range of motion. Try and limit compensatory movements as much as possible and get as normalized movement as possible. And then watch out and document how many reps they can do, what the quality of movement is, the degrees that they reached, all of the findings for the range of motion. Okay, that is our lecture for today on range of motion. We will be practicing this in lab, and just please let me know if you have any questions.